I said, type 2 diabetes in general is like reaching some very alarming statistics worldwide. So it's now estimated that more than 400 million people are affected with diabetes. And the sad part of it, that those numbers are going higher. So for example, it's estimated that those number will reach about 600 million people by 2035. So this is why now it's important to understand the pathophysiology of this disease and develop different therapeutic strategy to treat this diabetes. But what is diabetes? So according to Diabetes Canada, the diagnostic of this disease is if person has fasting plasma glucose level, so the concentration of the glucose in the plasma at the fasted state higher than 7 millimolar, or if the glycated hemoglobin, or what we call it A1C, is higher than 6.5%. And another way to diagnose this hyperglycemia or diabetes is by doing an oral glucose tolerance test. Is a condition where a person is fasting for overnight and then it's given 70 grams of glucose. And after 2 hours, if the glycemia is higher than 11.1 millimolar glucose, is a criteria to diagnose diabetes on those patients. So the hyperglycemia is caused by two main dysfunctions that are observed, particularly in type 2 diabetes. The first is a reduction of insulin. So the insulin is the hormone that is secreted by pancreatic beta cells, and basically is the only hormones that we have in our body that is able to reduce the glycemia. So if we have beta cell dysfunction, reduction of insulin secretion is one arm of the pathogenesis of this disease. The other arm of this type 2 diabetes is when the action of insulin is reduced, or what we call insulin resistance. Basically, the organs that are targeted with the insulin are insensitive to this hormone. And this organ, basically, in normal condition, they will increase the glucose uptake in the muscle, reduce the glucose production in the liver, and the lipolysis in the fatty acid, in the adipose tissue. So if we have insulin resistance, the glucose is not stored and used, and this participates in the hyperglycemia. So knowing all this mechanism, so the idea of developing therapeutic strategy is to try to enhance insulin secretion and protect from this insulin resistance. And the first way to target this or to treat this diabetes, type 2 diabetes, and this is the first generation of type 2 diabetes drugs, is to target pancreatic beta cells and increase insulin secretion. So the pancreatic beta cells are those cells that are present in the endocrine pancreas, or what we call the pancreatic islets. And these islets contain basically two main cells. Other cells are present, but we find the beta cells that secrete insulin and the alpha cells that secrete the glucagon. So the insulin secreted, as we mentioned, in response to hyperglycemia, so have we this increase of the glucose concentration, and through different intracellular mechanism we have that involves the mitochondria, the TCA cycle, the generation of different metabolic coupling factor. It induces or the insulin granular release, or the exocytosis of insulin granules. And as I promised, I don't want to go through in details of this basic information. I wanted just to summarize this pathways in way to understand how we can use this understanding to develop different drugs to treat diabetes. So this complicated pathways, I want to just to summarize it like this. So we have the higher glucose concentration in the blood, in the beta cells. So the glucose will enter to the beta cells and will be metabolized by the glucokinase and the TCA cycle within the mitochondria. and this will lead to the increase of the ATP to the ADP ratio. This actually triggers the closure of the KTP channel, and because the potassium is not released or travel through this channel and it's accumulated inside the cells, it causes membrane depolarization, the same thing that is observed, for example, in neuronal cells. This membrane depolarization will trigger the opening of the voltage-dependent calcium channel, and this intracellular increase of the concentration of the calcium in the cells trigger the release of insulin granules by exocytosis. So this is what we call the triggering pathway, and the amplitude of insulin secreted is actually modulated by this metabolic coupling factor, this arrow that I showed you in the previous slides. So this metabolic coupling factor can enhance, amplify the insulin secretion. And what was really interesting and we observed is that this amplification of insulin secretion is dysfunctional in patients with type 2 diabetes. So in this study, what we showed is when pancreatic beta cells were isolated from donors, cadaveric donors with non-diabetes or diabetes, and we measured the exocytosis or insulin secretion here, we observed that at the high glucose concentration actually induces or amplify the exocytosis and amplify insulin secretion. And it's obvious that this amplification is dysfunctional in pancreatic beta cells isolated from patients with type 2 diabetes. But what was really interesting to observe in that study is when we reintroduced in the beta cells some of this metabolic coupling factor, like the NADPH or the GSH, the glutathione, we observed that we were able to amplify the insulin secretion in the beta cells that are isolated from type 2 diabetes patient. So basically what this means is that the beta cells in patients with type 2 diabetes, they keep their ability to secrete insulin, and all this medication that I will talk later about them is to target the beta cells to enhance the insulin secretion in patients with type 2 diabetes. The first class of this treatment was what is called the KTP channel blocker, or what we call the sulfonylurea. Actually, these are a chemical agent or pharmacological agent that will close the KTP channel, will mimic the effect of glucose on this channel, and by closing the channel, we have this increase of the intracellular calcium, and we have the induction of this triggering pathway of insulin secretion. There is different class of this drug that are commercially available. But what is the problem with this medication is that the sulfonylurea actually is acting independently of the glucose, which means that if a patient or the concentration of the glucose of this patient is low, the sulfonylurea is still able to induce insulin secretion. And the problem with that is if we have secretion of insulin secretion in the absence of hyperglycemia, we have the opposite. We have the hypoglycemia. And basically, this is the side effects of this drug, all the sulfonylurea. They observe a significant hypoglycemic episodes in those patients treated with the sulfonylurea. Different clinical studies show this hypoglycemic effect. Besides those patients that were treated with the sulfonylurea, they gain weight. So those are main side effects with the sulfonylurea. And in addition, clinical studies showed that the sulfonylurea are also associated with different cardiovascular dysfunction, and also in some cases, the cardiac arrest that can cause death. So this class of medication is the mostly used because it's cheaper, but it has very important side effect, that the importance why now it's important to develop a new class of these anti-diabetic drugs without those side effects. Another old drug that is used is called the metformin. Actually, this drug was extracted from this plant, which is called the French lilac. And according to the World Health Organization, is the most prescribed drug to treat type 2 diabetes, the metformin, and also the sulfonylurea is the two main drugs because actually they are cheaper. But the metformin, at the opposite of the sulfonylurea, has very potent anti-diabetic effect because actually it enhanced this insulin resistance that I discussed before. So the organs are more sensitive to the insulin. And the main effects of the metformin, actually, it reduces the gluconeogenesis. So it reduces the production of the glucose by the liver. This is a very fantastic drug because we know that the metformin works, but we don't know how it works. There is different hypotheses how the metformin can reduce the glycemia or the gluconeogenesis. One hypothesis among another is that the metformin can inhibit the complex 1 within the electron transport chain. And by reducing this activity of the mitochondria, there is reduction of the ATP production, increase of the AMP level, which activate the AMP kinase, and the activation of the AMP kinase actually regulate the expression of the gluconeogenic genes. So the metformin is still the best drug, cheap drug that can be used to treat the diabetes. But the idea now, like to develop new drugs, is why we just focus in targeting the hyperglycemia, why we cannot develop other medication or pharmacological drugs that can protect against hyperglycemia, but can have also other effects, beneficial effects, like the cardiovascular or the renal function improvement. And this is the new class of medication that I would like to talk about them today. So the first class of this drug is based on this observation that has been made like many years ago, like around the 1970, that if we give the glucose to a person, those are healthy people, and we give them the glucose by oral or by intravenous delivery, actually we observe that the glucose concentration is basically the same between the two groups. But what is really interesting to see is if we give the glucose by oral versus the glucose given by intravenous injection, the concentration of the circulating glucose or the insulin secreted by beta cells was much higher when we give it by oral. So this information, as I said before, whether we can not target the beta cells and increase the insulin secretion based on this observation. To explain this effect, I would like to take you back a little bit to your physiology classes and just to see how the glucose actually acts in the digestive system, because the glucose is given by oral and this effect is dependent on this oral delivery of the glucose. So something in the digestive system that can mediate this potentiation of insulin secretion. And within the intestine, what we have these different cells, like in the small intestine here, that the epithelial cells, that their function is to absorb nutrients and the glucose as well. But we have also those cells called enteroendocrine cells. So those basically are cells that secrete hormones. And among the hormones that those cells secrete are the GLP-1 for the glucagon-like peptide 1, and the other hormone is the glucagon-dependent insulinotropic peptide, or the GIP. So this incretin effect, so this potentiation of insulin secretion, or what we call the incretin effect, actually is dependent on this GLP-1 and the GIP. So I will take you back a little bit again to the beta cells and see how those GLP-1 and the GIP works to potentiate the insulin secretion. So you can see that this is a little bit complicated, but I will try to explain it step by step. But basically, the GLP-1 and the GIP actually are an agonist, like two receptors, which is a GLP-1 receptor and the GIP receptor that are G-coupled protein receptor. So how the system works in the beta cells, when the GLP-1 or the GIP bind to the receptor, the G-alpha S will activate this protein called the adenylate cyclase, and the adenylate cyclase will metabolize the ATP to produce the cyclic AMP, and the cyclic AMP activate two key proteins. The first one is the EPAC, for exchange protein activated by the cyclic AMP, and the EPAC will activate receptors within the reticulum, endoplasmic reticulum, to increase the release of the calcium from the reticulum stores. The PKA, the same way, or the protein kinase A that is activated by the cyclic AMP, will act through another receptor called the IP3 receptor that increases the intracellular calcium level. The PKA can act also to close the KTP channel and open the voltage-dependent calcium channels, and altogether, these mechanisms will have an effect on increasing the intracellular calcium level that can explain this potentiation of insulin secretion by the GLP-1 and the GIP. The GLP-1 has also the particularity to be coupled to the G-alpha Q, and this activation, or G-alpha Q, can activate the PLC, phospholipase C, that can produce the IP3. The IP3, the same way, will increase the intracellular calcium level. The DAG can activate two other proteins, which call the PKD1, protein kinase D1, or the protein kinase C, and altogether will increase the recruitment of more vesicles or insulin granules to the plasma membrane to enhance the insulin secretion. So based on this observation, or this incretin effect, different pharmaceutical companies started to target these receptors, and particularly the GLP-1, and developed the GLP-1 receptor agonist. The first one was the exenatide, so here, called beta, and actually the exenatide was discovered in the saliva of this lizard called the Gila monster, and that was the first GLP-1 receptor agonist in the market to treat type 2 diabetes. And since then, there is other version of the GLP-1 receptor agonists. Some are short-acting, some are long-acting agonists that can potentiate the insulin secretion and are used to treat type 2 diabetes. So some clinical studies showed their effects. So this is why they are used. Actually, we see the short-acting and the long-acting agonists. We can see that they reduce the fasting plasma glucose. They improve the HbA1c, as I mentioned before, is one of the criteria to diagnose type 2 diabetes. But what was really interesting to observe is that those GLP-1 receptor agonists, besides their effect to improve the glycemia, they reduce body weight. So they have a significant reduction of the body weight. And maybe one of the famous one that now is in the market is called the semaglutide, or the Ozempic, that actually now can be prescribed to treat obesity. So again, in the same idea of developing drug to treat type 2 diabetes, those new generation of the anti-diabetic drug can have also other effects, for example, here to treat obesity. So how we can explain their effects of the GLP-1? So I said that the GLP-1 can improve the glycemia by targeting beta cells, but also can improve the insulin resistance at the adipose tissue or the muscle. But their anti-obesity effect can be explained by their action on the brain to decrease the appetite and increase the satiety, or to increase the lipolysis to reduce the number or the fat within the adipose tissue, and also can increase or decrease the gastric emptying. So all these effects can explain the effects of the GLP-1 receptor agonist in treating obesity. And there is some new indication showing that the GLP-1 receptor agonist can have some cardioprotective effects. So this is the first generation, or this is the first arm of the incretin effect. So the question then is why we can just inject different GLP-1 agonists, why we cannot just inject our own GLP-1 to treat diabetes. So the idea beside that, or why we cannot do that, because the GLP-1 and the GIP are very unstable. So they are rapidly deactivated by this protein called the DPP4 or the dipeptidyl peptidase 4. And this DPP4 will cleave these two peptides, these two first amino acids of these two peptides, and the GLP-1 and the GIP is inactive. And based on this observation, another generation of anti-diabetic drugs is to use the DPP4 inhibitor. And basically what it does, it increases the stability of the endogenous GLP-1 and GIP, and can be used to treat diabetes and increase the insulin secretion. Different clinical trials showing their effects on improving the HbA1c. So there is a significant reduction in HbA1c, and which is really interesting to observe that those DPP4 inhibitor, the improve, for example, sitagliptin, improve the HbA1c without any gain weight, as it has been observed with the sulfonylurea, as we discussed before, or with the hypoglycemic events are also very reduced with this anti-diabetic drugs. So there's now two medications that are targeting the incretin effect, but what about the GIP? So the GIP is, as I said, is also an incretin hormone that is secreted by the gut or by the intestinal cells, but so far there is no specific GIP receptor agonist that is used to treat diabetes. But the new generation of this incretin therapy is to use those co-agonists, which is the GIP and GLP-1 receptor co-agonist, which is called the tirzepatide. And this is really new. It has been approved last year, about a year now, by the FDA, and is used in US to treat diabetes. But also there is more indication that the tirzepatide does not have only an effect to improve the glycemia, but also to treat obesity. So the clinical trial showed that if we compare the tirzepatide, the semaglutide, which is a GLP-1 receptor agonist, has a strong effect in improving the glycemia. This is the change in the HbA1c, strong reduction in the HbA1c compared to the semaglutide, and also the change in the body weight. So there is a reduction about 11 kilograms in people treated for 40 weeks with the tirzepatide. The study, like the follow-up study, was 72 weeks, and interesting to observe that people with tirzepatide, they have about 20 kilograms reduction in their body weight, and about 90% of the patients that were treated with this co-agonist, they have at least 5% reduction in their body weight. So this is like very important observation, but the side effect of these incretin hormones that they can cause the nausea, diarrhea, and the constipation. So these are the GLP-1 and the GIP. And based on this observation that we can target two receptors at the same time with the same peptide, now the trend is to develop other agonists that they can target more than one receptor. And this is the new generation. This is a new study that was published like last year, like December of last year, where Eli Lilly published their new peptide that actually is a co-agonist of the GLP-1, the GIP, and the glucagon receptor. So three together can be activated by the same receptor. And they released their first clinical trial. And actually what they observed, so they compared this triple agonist to the GLP-1 receptor agonist, the dulaglutide, and they observed a strong reduction of the HbA1c and also a strong reduction of the body weight on those patients treated with this three agonists. More observation in this studies or this clinical studies. So beside the reduction of the HbA1c, they have also and the body weight, they have reduction of the waist circumference, which is one of the criteria to diagnose the metabolic syndrome. They have reduction of the fasting blood glucose. They have increase of their insulin secretion or stimulated insulin secretion. So this new agonist that has been published last year maybe is the new generation of incretin hormones or receptor agonists that can be used to treat diabetes, and the competition is high. So Eli Lilly published their first clinical study. Now Novo Nordisk also, they have their own GLP-1 GIP glucagon agonist, which called the compound 16. And in this preclinical study in mice, they observed a significant reduction in the body weight, and actually the effect of this compound 16 at least in mice is more potent than the tirzepatide. And remember, the tirzepatide is the one that's targeting only the GLP-1 and the GIP receptor agonist. So this is another arm to treat diabetes is to target the GLP-1 and the GIP receptors. But let's go back again and understand our physiology and see how we can target those physiological mechanism to treat diabetes. And I will take you again in this glucose journey in our body after moving from the digestive system to the circulation. The last step maybe of the glucose is when it enters our renal system. And actually the glucose, if we go back to your physiology classes, this is actually one of my slides that I use for my class. You can see that the secretion of the glucose in the urine is zero. So all the glucose is reabsorbed by our renal system, going back to our circulation. So how the glucose is reabsorbed by the renal cells, or epithelial renal cells, we have this co-transporter of the glucose and the sodium, and actually the glucose actually is going back to the circulation in the same time with the sodium by this transporter. And one way to treat diabetes, you can imagine, is if we can stop this reabsorption of the glucose in the renal cells. So the glucose, instead of going back to the circulation, it will be secreted or excreted in the urine. And this is another class of anti-diabetic drugs that are called the GLT2 inhibitors. The SGLT2 actually is the co-transporter of the glucose and the sodium. And this class of drug, it inhibits the action of this co-transporter in the renal system. And what is observed is that this transporter or this inhibitor in different clinical trials have a very significant impact in reducing the glycemia as measured here by the HbA1c, but also what was interesting to observe that the SGLT2 inhibitors actually improve the systolic blood pressure. So based on this observation, there is more clinical trial that showed that the SGLT2 inhibitors, besides their effect to treat diabetes, they can also be used to treat cardiovascular disease. And now the SGLT2 inhibitors start to be prescribed for patients with cardiovascular disease. So here are different clinical trials to observe that the use of the sodium glucose transporter inhibitor or SGLT2 inhibitors actually improves like the cardiovascular outcomes at different levels. We see here this reduction of or improvement of the cardiovascular outcomes and also the cardiac death, also the hospitalization after the treatment or of the cardiovascular disease. We in the lab interested to understand the effect of these inhibitors at the cardiovascular level. And actually what we showed is that SGLT2 inhibitors, particularly the empagliflozin, reduces actually the cardiomyocyte hypertrophy in the cardiovascular disease. We observed that these inhibitors actually prevent the activation of the inflammasome and the inflammation, improve the fibrosis, like reduce the fibrosis in the cardiovascular setting. And some other studies showed that the SGLT2 inhibitor can increase the ATP production, which provide more energy for the heart and preserve its function. So again, when we like this new generation of the anti-diabetic drugs, they are not only good for diabetes, more studies show that they are also beneficial for other adverse effects and comorbidity with the diabetes, like the cardiovascular disease here or the renal disease. Actually, the renal also function is improved with the SGLT2 inhibitor in different clinical trials. And one of our studies showed that this inhibitor, the empagliflozin SGLT2 inhibitor, actually reduces the inflammation and the renal injury in a septic shock model. So again, we can target our physiology. We can understand a lot from our physiology to target different mechanisms to treat type 2 diabetes. So far, what I was talking about is to treat diabetes, but the question, maybe the more important question is, can we cure diabetes? Can we have a remission of diabetes? And actually it is possible. So according to Diabetes Canada, we can have the remission of type 2 diabetes and is defined by achieving the A1C threshold, like the target of the EB1C without any anti-hyperglycemic agent, with any medication. And actually this is possible. How it's possible to treat diabetes or to cure diabetes, or to be more precise, we can have remission of diabetes. One observation was in people that they like with obesity, that they have the bariatric surgery. So this is a surgery that is prescribed for people that they have morbid obesity. And the idea behind this surgery actually is to decrease the nutrient absorption. So there is one surgery, the two famous or more used surgeries, the first one is the Roux-en-Y gastric bypass. Actually, the idea is to remove the stomach and to take parts of the intestine and link it to the small parts of the stomach. So all the nutrients will bypass like the stomach and goes directly to the intestine, and there is less digestion and less absorption of nutrients, and this can reduce the obesity. The other surgery that is mostly used, what called the sleeve gastrectomy, and actually this surgery is basically remove a big chunk of the stomach. We just keep about 20% of the stomach or a sleeve. This is why we call it the gastric sleeve gastrectomy. And in the same idea, we have a reduction of nutrient digestion and absorption. So this surgery is prescribed for people with morbid obesity. But what was really interesting to observe in this patient is that if they have diabetes, they observe a complete remission of diabetes. So these people are free of medication. So here, after 2 years and after 5 years, this is a Swedish study. And what they observe is, depending on the duration of diabetes, the success of the remission is higher if the diabetes was diagnosed very early. And this remission can be observed 5 years after this bariatric surgery. How we can explain this? So there's difficult to explain how the bariatric surgery can induce or can cause this type 2 diabetes remission. But what is really clear from the different clinical studies that the remission of diabetes is independent of weight loss. So it's not because the people they have less obesity, this is why they have their diabetes that disappear. Actually, this remission is independent of the weight loss. And there is different hypotheses. Among this hypothesis, one that we discussed today is to increase the level of the GLP-1, this incretin hormone that is secreted by the gut. There is also hypothesis that it increased the insulin sensitivity. Other hypotheses suggest that it involved the bile acid or other hormones that are secreted by the liver, or what we call the hepatokine, like the FGF19. So far, we know that the bariatric surgery can cause the remission of type 2 diabetes, but we still don't understand by which mechanism the bariatric surgery can mediate this effect. So I tried here in today's seminar to highlight the molecular perspective and the mechanisms by which we can target our physiological system to improve the glycemia. And if I have a message for you, like a take-home message today, is if we can understand our physiology, we can develop different strategies to treat type 2 diabetes. So what I presented today, so I want just to summarize what we discussed today based on the molecular mechanism perspective of this anti-diabetic drugs. So the first one I discussed, and the first class of this drug is the sulfonylurea, that has only one effect, is to increase the insulin secretion. And since then, different class of anti-diabetic drugs that are developed, like the GLP-1 and the GIP agonists, co-agonists, or triple agonists, that actually increase the insulin secretion or potentiate the insulin secretion. There is some study showing that it increases also the beta cell proliferation. More beta cells, more insulin secreted. We published one study showing that the GLP-1, for example, reduces the beta cell apoptosis by targeting the GNK pathway. So we have also less cell death with the GLP-1 and the GIP. So again, more beta cells, more insulin secreted. The other effect of the GLP-1 and the GIP is to reduce the glucagon secretion. We discussed also that the GLP-1 and the GIP are very unstable in our bodies, so we can increase their stability by using the DPP-4 inhibitors. Another magical treatment for diabetes is the metformin, that is very potent to improve the glucose or insulin sensitivity and reduce the gluconeogenesis, which is the metformin. So we know that this drug works to treat diabetes, but still we don't have a mechanism, exact mechanism by which the metformin can improve the glycemia. Again, taking you back to our physiological system, we can improve the glycemia by inhibiting this glucose and sodium transporter, or the SGLT2 inhibitor. And the idea behind this is to increase the excretion of the glucose in the urine. And again, it will reduce the hyperglycemia observed in patients with type 2 diabetes. So all those treatments are to treat diabetes, but we have this key observation that the bariatric surgery can cause the type 2 diabetes remission. So I think for now, the future of research is to understand how this remission of type 2 diabetes occurs, and if we can develop a holistic strategy to develop different medication or treatment to not to treat, but to cure diabetes. And all this new generation of the anti-diabetic drugs, they not only improve the glycemia, they also have other beneficial effects by improving, like by reducing the obesity, have some cardioprotective effect, improving the renal function. They have anti-inflammatory effect, like the sepsis that I showed you. We have also some results showing that also reduces the IBD in some preclinical study by using some of these anti-diabetic drugs. So my take-home message and my last slide for today is, if we can understand better our physiology, is a very good resource for us to develop new therapeutic strategy to treat diabetes, but not only diabetes, also the comorbidity associated with this disease.